Good morning. I'm Dr. Qazi Tariqul Islam, immediate past governor of the Bangladesh chapter of the American College of Physicians. I'm the master of the ACP, and here I'm as an ambassador from the ACP. The American College of Physicians, how they are fostering excellence and professionalism in internal medicine, I will just finish it by 5 to 7 minutes. Actually, this is 100 plus. In 2015, they celebrate the 100 years of their college in Boston, and I had been there. They have the headquarters in Philadelphia, and also there is an office in Washington, D.C. The founder of ACP, Dr. Stern, actually in 1913, the Royal College of London, he participated there, and in 14, together with 6 colleagues, they convened the American College of Internal Medicine to facilitate scientific exchange among doctors interested in internal medicine. And thereafter, in 1915, incorporation in the American College of Physicians. Actually, who we are in the American College, they are the internists, apply scientific knowledge, clinical expertise to the diagnosis, treatment, and compassionate care of adults across the spectrum from health to complex illness. The SCP community include internist, internal medicine subspecialists, resident, and fellows in training, as well as medical students. SCP is a global community, nearly 154,000. They have the member, fellows, residents, and all together that I have mentioned, and almost 10% outside US. So non-US SCP members, fellows, and others, they are almost 10%. They have international chapter. This is alphabetically arranged. So the international chapters are Bangladesh, Brazil, Caribbean. Canada has 6 chapters of different region. Central America, Chile, Colombia, India, Japan, Mexico, Saudi Arabia, and for the whole Southeast Asian region, there is one. At this moment, the governor is from Singapore. And finally, Venezuela. Collaboration with several internal medicine societies outside the United States, as with the Sri Lankan Society also. What we do, actually, every society, every professional body, they promote the highest clinical standard. This is for everybody, for ACP, for the Royal College, for Sri Lankan Society, Bangladesh Society, everywhere. But this is very basic thing, no matter. But the way ACP is doing is completely different, as I have seen. And they have the MaxUp 17. This is a very nice tool for developing yourself in the internal medicine. Very innovative in education, support our member and their patient. They make the webinar depends on your demand of the society, they make it. Again, promote internal medicine as a career, and also in some crisis, they do some demonstration. ACP fellowship in the college is an honor. Being a FSCP is a distinction earned from colleagues who recognize your accomplishment and achievement in the practice of internal medicine. You can go to www.acponline.org/FSCP. You can get the form. Those who are member for 2 years or those who are senior professor, they can directly go for direct fellowship. So there are 2 ways, from member to fellow or direct fellow. So direct fellowship you can do, and 2 of your colleague can propose, and you know this. And I'm almost at the end of my lecture. Patients' education material. This is 25 clinical condition instructional videos, and all these are available. You can purchase it. You can have it from website. Patient care tools. This is very important. There are some. They are dealing with end-of-life decision-making, other information. This is very helpful for doctor-patient relationship. There are many other things, but in short, international newsletter, international council, the SCP governance, because when there is a chapter, each chapter must have to at least make a newsletter every 6 months. But there are many other chapters in the United States, they make at least every monthly or bi-monthly, something like that. International Fellowship Exchange Program. This is a very important part that I want to make more light on this, because from my country up till now, at least in different time, 4 or 5 doctors, they have gone to the United States for International Fellowship Exchange Program on different, depends on the vacancy. And this is a worldwide competition. Very good proposal has to be made, and the competition after that, they usually offer 3 to 4 scholarship per year. So I think you have very talented people over here, and you can go for. And for this, only you need to be a member, not fellow. So junior doctor or mid-level postgraduate physician, they can. Yes, this an ambassador, as I am here, and in the next time, maybe somebody else will come, but this goes on. Educational program, I told you that this is gone through the webinar. We used to make webinar in Bangladesh in different time, direct webinar. The concerned people is giving lecture in the United States, and we are lively talking with them, sharing our knowledge, something like that. And members online forum, there is another forum. Register and enjoy. This is something that 11 to 13, 2019 in Philadelphia. This is the meeting announcement, and on behalf of SCP, I am inviting you to join there. And for any other queries, questions, you can contact the international office at scponline.org. And thank you for your patience hearing. If there is any question, I'm ready to, I will try to give answer to that. If I cannot, you can contact them because I'm the representative, ambassador of them. Maybe all the question I cannot be able to satisfy you. Thank you very much.
We could use that as app on your phone, and now they don't allow that either. You have to, every time you want to do something, you have to log in, put your ACP password, everything, and log in. And like if you go to do something and come back, they have logged you off, so you have to log in again.
So this is the question of
just a comment. No, just a comment of the facilities that are available for members and fellows.
Yeah, this is the facility. That is
Yeah, it's becoming less and less.
But the question is, every time you are going and login fresh.
No, it's just a comment. The facilities are becoming less and less.
That's great.
Yeah.
And
Yeah.
when you will be in the, say, for example, in the annual conference, you will get all in your apps, everything, and you can download almost everything after the session is over. And you can have all these lectures and everything. Because knowledge is for sharing. And SCP is very much broad in that sense. They share everything, and after and there are many hands-on sessions during pre-conference, what you did in the day before yesterday, and during conference. And this is the advantage that we used to share, and we are also benefiting. Good. Thank you.
Welcome to the SimCon Day 2 2018. We are going to start our first plenary lecture. Let me introduce Dr. Lim Si Yi. He is a specialist in hemato-oncology and hematopoietic stem cell transplantation in Singapore. Let me invite him to talk on current trends in hematology. Over to you, sir.
Thank you very much. Thank you, everyone, for coming, and thank you, Chairman, for inviting me today. So I've been given the task of talking about current trends in hematology. Should I use that? Okay. And to start with, can you hear me? Yeah. So to start with, I just like to say hematology is an extremely diverse subject. And so covering the scope of current trends in hematology is going to be quite a challenging task in the next 25 minutes. So I'm just going to summarize some areas and focus on some specific areas which I think are relevant to the changes in the practice over the next 5 to 10 years. But the scope of hematology encompasses both benign hematology. And benign hematology actually is, I like to say hematology quite often is a reflection of what happens in many other organs in the body. So I get referrals. I'm a hemato-oncologist, but I do manage a lot of general hematology, and I get calls from obstetrician, gynecologists, from acute medicine internists, and things for a variety of complications related to abnormalities in hematological indices like iron deficiency anemia, transfusion clotting disorders like DIVC, up to inherited blood disorders. But a bulk of my practice is also related to malignant hematology. And just to show you the scope of change in hematological oncology over the last 50 years from there. So some areas of hematology, like acute lymphoblastic leukemia, it's been a very dramatic change. It's been one of the great success stories of medicine, in that if you were looking at the 1950s to 60s, the cure rates for children was around 5 to 10%. Now in many parts of Asia, we're looking at cure rates around 80 to 90%. Yeah. And for many other of the diseases as well. So how are we getting there? What are the important things which have improved hematology? So 3 areas I'm going to touch on. One is the importance of diagnostics, both complicated diagnostics as well as simple, just clinical observations. 2, the use of very new therapeutics now. We have a lot of new drugs which we can use for treating different types of hematological disorders. But 3, one area I do want to touch on as well, and it's quite relevant in this part of the world, is the escalating costs related to the treatment of hematology, which is a big challenge for us in this field as well. So in terms of diagnosis of hematological disorders, I think Professor Bell highlighted this. I wasn't at his talk, but I heard. I think one of the key important things still with making a diagnosis is careful clinical evaluation of patient, and sometimes looking at the baseline results of patients. So many times I get asked to make a general consult on a patient, and quite often by just looking at the results which you have on hand and looking at the patient, you can actually draw a good, reasonable conclusion of what a patient may have. You don't always have to go into a barrage of tests. And I always, again, as I said, hematological abnormalities sometimes can be due to a primary hematological problem, but often can be a manifestation of a more systemic problem. So this is the award-winning abstract from yesterday, which again shows that platelet dysfunction abnormalities can be a reflection of other things like infections. So if we look at things like thrombocytopenia, which is a common cause of referral, there are many, many causes of thrombocytopenia that we know of. Some are more common, some are rare from there. And when we get asked to see a patient with thrombocytopenia, we don't run through the whole list of these diagnoses immediately. So one of the things I always tell trainees is common things tend to be common. You need to think about the rare things, But you obviously, when you see someone, you still need to run through the most common things first when you look at your approach to diagnosing a patient or treating a patient. And this table, which I'll circulate, all the different tests that you can run. This is from our annual meeting on the different tests you can run for someone with low platelet count. You don't have to run through everything, yeah? Quite often if someone has a thrombocytopenia, the simple thing is looking at the patient, looking at the blood film from there to see if it's clumps, looking to see if it's a true thrombocytopenia, are there other counts involved, and are there other systemic clues from a patient which may guide you along the way. Quite often, is the patient septic, for example, or their autoimmune features. And in many cases, it's related to either infections, for example, or autoimmune conditions. And in which case, many cases, you don't necessarily have to treat a patient from there. So it's just taking a systematic approach. I'm not going to go through this in much detail. Another thing which I get asked, again, this is where actually we always say, are these MRCP questions relevant, MCQ questions relevant? But in real life, I get patients like this coming through my door once or twice a week. Yeah, patients who have seen either an orthopedic surgeon, a renal physician sometimes, or even a general practitioner for a while sometimes. Patients with, let's say, a progressive normochromic normocytic anemia, raised ESRs are very high, raised globulins and albumins, and they eventually present either with progressive renal failure, sometimes with crashing renal failure, or sometimes with a pathological fracture. Yeah? And in many cases, for me, it's a spot diagnosis. You look at it, it's actually a condition called myeloma. Classical training, we know it has high calcium. They don't always present with that, but sometimes progressive renal impairment, proteinuria, anemia, bone abnormalities. So sometimes it's important for generalists to recognize these signs as well. You may not be correct in the diagnosis. Sometimes autoimmune conditions can cause a similar manifestation, but having heightened awareness to know when to refer on to a specialist for further treatment. So if you need treatment, then there's certain diagnostic procedures that we tend to do. I mean, we tend to do a bone marrow quite often when we think it's a serious hematological condition. Microscopy is still very important, and many of you who may remember this FAB classification where we look at acute leukemia from M1 to M7. One of the great things about the UK training system for hematology is that you have to do pathology. And that's a very, very useful skill. And actually it's one of the most gratifying things sometimes when you have someone presenting to you in A&E with a white cell count of, let's say, 50 to 100. You do a blood film, you go down to the microscope and you have a look, you see our rods, and you can make an immediate diagnosis of acute myeloid leukemia. And you can start treating and stabilizing the patient within an hour of seeing them. So having a fundamental knowledge of both medicine and pathology is still very important. There are other things that enhance our tests now, things like cytogenetics, where we look at karyotypes. This is a patient with abnormal karyotypes, and we can prognosticate patients for treatment. And we've now moved to an era of molecular medicine. I think, fortunately, many fields of medicine we're moving increasingly towards very in-depth testing. And this is penetrating many areas, both benign and malignant hematology. I tend to take a very practical approach to when I do this test still. In an ideal situation, you do it in all patients. Sometimes you have to decide whether you do it based on what drugs you have available. If you don't have the drugs necessary that will modify your treatment practice, you may not need to do this test at certain stages from there. It depends on the means you have available. So that's about diagnosis. Then what about treatment of patients with hematological disorders then? So again, I'm just touching briefly on it, yeah, because if you look at oncology for one, there are many treatments we've had. We don't use surgery much now. Chemotherapy is still a mainstay. Radiation therapy is important sometimes, and targeted therapy. And one of the things which has become very challenging in the field of oncology, for example, is that there has been an explosion of drugs available now. If you look at this, this is again treatment algorithm for myeloma. In 1950s, we had melphalan, which is a very old but useful drug and very cheap drug. I still use that regularly. Steroids, moving on to transplants. But in the last decade, we've had an explosion of very, very powerful and wonderful drugs available. And hence, this is one of the challenges in modern medicine we face. And this is a representation I want to show you. Because if you look at it in US and the US healthcare model, which is largely insurance-based, healthcare costs have escalated significantly. So the number of new myelomas in the US is expected to be 30,000 a year, at least for the next few years. And the total lifetime cost of treating all these patients, you're looking at $22.4 billion. That's enough to bankrupt many countries from there. Yeah? And one of the reasons for this is if you look at the drugs, this is a cost per annum per drug per patient. So when I started practicing hematology, we're looking at costs of drugs which are around $1,000 a month were considered expensive. Nowadays, drugs are regularly exceeding costs of $10,000 per month per patient from there. And the problem you have is that you don't use single agent drugs. People are moving towards combination therapies from there. Yeah? And combination therapies, unfortunately, even in where I work, Singapore, many patients can't afford this, and it's hard to sustain this sort of healthcare for many patients from there, particularly in an Asian set model where quite often government's reimbursement is not so good and insurance is not widespread from there. Healthcare, particularly in regards to hematology, is a point of concern for me. For the healthcare cost of blood cancers, for example, actually double the cost of cancer care for other types of solid tumor cancers, largely because patients are older, they're more sick, and they need to be in hospital for longer. So if you look at it, again, the total cost of treating blood disorders to the European economy is $23 billion a year. So that's a significant cost. So one of the things is how can we draw lessons from Western practices and translate them to care, for example, in Sri Lanka or our region, for example, with different healthcare models. That's one of the things that we constantly have to look at whenever we look at data when we go to conferences in US or UK, for example. Yeah. Relying more on clinical skills, I like to say that. I mean, ultimately, that's important in terms of how you rationalize healthcare. Using appropriate testing is important. Where I come from nowadays, increasingly, there's a tendency to do a whole battery of tests for everything that patients do, but being selective in terms of the tests you do is important. Tailoring it and partnering to the treatments you can afford to give the patient. Working to manage the cost pathway. And when you talk about cost pathway, one of the important things I find treating patients, for example, I've got many patients in Sri Lanka or India, sometimes is using other drugs available. Generic drugs, I think that's a bad word in a way, but actually the generic industry has moved a lot. Even people in US are using more and more generic drugs for treating cancer. So choosing drugs which allow patients to get necessary treatment at a fraction of cost is important. Or agent-specific therapy. So one of the important things which has come out from our field is certainly if you look at countries like China and India, they have started to publish some very nice publications using treatments which lower cost treatments, using understanding the biology of treatment, by using lower cost treatments to achieve similar results. So again, it's tailoring the treatment based on what you have available. So it's creating treatments which can be sustainable in your own system. So talking about that and drawing reference then in terms of hematology to Sri Lanka then, I'd just like to touch on thalassemia. No? Thalassemia is a condition which is very common in this country. Yeah? It's estimated that there are 4,000 thalassemia major children. And importantly, it's estimated there may be up to 500,000 carriers in this country. We all know that thalassemia major patients have significant morbidity and mortality through their lives, and a lot of it's related to lifelong blood transfusions, the cost of transfusions, and the cost of managing the complications from iron overload. And we know that there's a sort of slow escalation in terms of significance of mortality related to the burden of thalassemia. Thalassemia minor patients tend to have very little symptoms, but thalassemia major patients have shortened lifespans with a lot of problems with siderosis. It's important, hence, to be able to pick up the carriers in terms of family planning. And that's one of the things which has been noted, for example, in Sri Lanka. Many of these carriers are not screened beforehand historically, and that increases the risk of people having thalassemia major. One of the treatments which is important is allogeneic stem cell transplantation is increased worldwide. In Asia, it's very uncommon at the moment relatively to the rest of the world. And why? It's because we have lack of suitable donors, lack of trained physicians and staff, limitation of facilities, and certainly high cost of transplantation. But I think it's encouraging, and I think this is a very nice model in terms of how problems are being adapted in Sri Lanka. So certainly, the Lanka Thalassemia Circle and other physicians have been working quite hard to work on improved screening. And screening, again, doesn't necessarily mean that you actually screen specifically for thalassemia. Quite often, just doing a baseline hematology screen of a full blood count can tell you if someone has thalassemia. If someone is anemic, microcytic, if someone has a family history, that in itself is a good trigger to say this person has a high risk of passing on a thalassemic gene. But the second thing is certainly stem cell transplantation. Working in UK and Singapore, transplantation is a very expensive, labor-intensive procedure. But again, it's with the use of things like NGOs, like Curative Children has been working quite closely in Sri Lanka to try to create a more affordable healthcare model for transplantation, because it's a curative procedure. And certainly I know, speaking to my good friend Dr. Lalindra from Asri Hospital, they're doing like 20 transplants a year now for curative for children with thalassemia. And one of the important things is the cost. I think it's amazing having seen what they've been doing. They're able to do transplants at less than a tenth of the cost that would cost to do it in the Western world from there. And if you look at the health economic model from that, actually that versus giving children a lifelong of transfusions, iron chelation, and inpatient hospital stay, the economics, I think, do work out from there. So again, it's finding ways to adapt from there. So finally, I'm just gonna, do I have time, touch a bit on the future of hematology and future of medicine from there. So I know this is a bit taking a leap forward from there. One of the reasons I do want to touch on this, I'll come back to, is related to thalassemia again from there. So in the last few years, we've been looking at increasing exciting developments in treatment of cancer. And one of the areas which is very important in the field of medicine and is getting very exciting is this field of cell and gene therapy, where we can actually genetically modify cells to try to treat either cancers or genetic disorders. It's costly at the moment, though. So, for example, if you look at this, the first cell therapy which has been approved in US last year and now is going to be available in UK as well, this is a form of genetically engineered T cells from patients to treat cancer. The cost is phenomenal at the moment, $475,000 for one treatment. Yeah, but we expect it to come down. But why is it important? I'll show you. What this form of treatment is, genetically you can modify cancer cells now. You can arm cancer cells with receptors. And what these receptors do is that you allow a patient's immune system to specifically target cancer cells. And I'll show you a picture for that. What we do is that we know T cells play an important role in fighting cancer. But T cells in our body, after we've had cancer for a long time, don't always target cancer cells appropriately. So by creating genetically modified receptors on T cells, you can make them specific to these tumor cells so that they can target the tumor cells and not target normal tissue from there. And you have stimulation signals on these CAR T cells which stimulate the T cells so that they become much more potent. So if you look at a picture here, in a normal person, sometimes you have T cells which are energetic. They don't actually recognize the cancer cell here in red. You create a receptor on these T cells which can target these yellow triangles which are the receptor on cancer cells. Normal cells don't have the same receptors, so the CAR cells don't bind to those normal cells. They just target the cancer cells. But what you do is that when these CAR T cells then bind to the tumor target, you create special signals in them which stimulate these T cells to exponentially grow rapidly. So almost like it creates a targeted nuclear bomb around your cancer to kill the cancer from there. And does it work? We're seeing some very phenomenal results in patients who are very refractory. So this is one very nice example, for example, a patient with very aggressive lymphoma. And by treating it, you can see that one dose of treatment, these cells grow in the patient's body, and they keep growing, and they perpetually help to kind of remove and clear the cancer from there. And it's very positive data at the moment for different types of blood cancers. And now it's moved to the field of solid tumors from there. So cell and gene therapy for cancer is a very big area. But it's a very costly area. But where I think it's quite interesting in relevance to Sri Lanka is another area of gene therapy. And this year at our annual meeting in 2 months' time in the US, they're going to be presenting updated results. But we know conditions, inherited genetic conditions like thalassemia are extremely high cost and have a high burden. And people are now looking at how can you genetically modify and treat conditions like thalassemia. Because if you can genetically modify and treat these conditions, potentially you can help to eradicate these conditions from there. And one particular company, Bluebird, and a few other companies are looking at ways in which they can do this to treat children with thalassemia from there. And data is coming out. One of the big challenges with this is, of course, with big pharma involved comes big costs. And hence, this is interesting from there. Speaking to some people from Sri Lanka, how do you do something if you have emerging technologies which work very well? can you scale these down to ways in which you can do it in a local setup for that at a fraction of the cost? And that's, I think, one of the big challenges and one of the big potentials for places like Sri Lanka or the region, like India, Bangladesh, how you can work together to create ways in which you can use modern technology to treat inherited hematological disorders. And I think this is something which is going to be very exciting for the years forward from there. So that's just a very quick summary of the field of hematology, from basic diagnostics all the way to the future of hematology. I'll finish my talk there, and I'm very happy to take some questions. Thank you. Yeah.
Thank you very much, Dr. Lim, for that very exciting lecture. I'm sure there must be questions from the audience. He'll be very happy to answer.
Thanks very much. That was a great talk. Cancer cells are quite innovative as well, and do change the receptor status, etc., etc. So is it better for hematological malignancies because they may be monoclonal as opposed to solid tumours, which often change their profile quite rapidly?
Yes, so I think, yeah, you're right. So that's why I think talking about specifically cellular therapy, CAR T-cell therapy, the first wave of treatments have all been with hematological malignancies, mainly because they're liquid tumors, they're all around, and they've got very defined receptors. It's quite a complicated field, and one of the reasons we've now realized that it doesn't work so well in solid tumors is sometimes it's very hard for the immune cells to infiltrate into the solid tumor environment. There's a whole field separately about the microenvironment of solid tumors and how you need to break down those defenses to allow these cells to go in. So it's, one, having targets for these cell therapies to affect cancer cells, but two, you'll probably need adjuvant methods to help to unveil sort of the immune system to allow them to be effective. So that's a whole separate field, but I think interesting data which is coming through in the last few years for that. Yeah.
Any more questions? Yeah, in the absence of any further questions, may I now invite Professor Tilak Veeraratne to hand over a token of appreciation to Dr. Lim.